Hello, and thank you so much for joining us for our webinar today entitled Managing Function and Quality of Life of Head and Neck Cancer Survivors. We have a really wonderful group from the Kessler Institute for Rehabilitation here joining us today, including Dr. Michael Stubblefield, who's joined us for previous webinars and been a wonderful collaborator with us, and two of his colleagues, Jennifer Maximos Hrdina, who's a occupational therapist, and Brittany Boynton, who's a speech language pathologist. And they're going to talk about helping head and neck cancer survivors deal with radiation fibrosis, which can be an effective radiation which causes some hardening of the tissues and can result in loss of movement, inability to open the mouth, trouble speaking, trouble swallowing, etc. And they're going to tell you all about that and how to help cancer patients who are and survivors who have radiation fibrosis to live a better quality of life and to manage these side effects of the important treatment that they have. So I want to thank all of our team for helping us put this together. Thank all of you for joining us. Their bios will be in the chat because I don't want to take away from their time. And I will turn it over to you, Dr. Stubblefield.
Great, thank you. Let's see if I can do our share screen without screwing up too badly. All right. Well, thank you so much for that, Shelley. Also, thank you, Brittany and Jen, for joining me on this. So, I'm the medical director for cancer rehabilitation at Kessler. I'm also the national medical director for Select Medical and for our Vital Cancer Rehab program. And the joke is, at least as I tell it, that people come for me, but really they stay for the therapy. I'm just kind of the gateway to get you to what you really need most of the time. So what I want to talk about here is some of the common radiation-related effects associated with head and neck cancer. By way of disclosures, I've got a textbook, please knock yourself out. And also I'm a photographer, so I can't help but throw photos in when I'm giving talks, so pretty much all of them of mine are mine. So what we want to do is talk about what is messed up in head and neck cancer survivors, what things can happen to you. And then we want to talk about how they're diagnosed, how you go about having them treated at least as well as possible. Unfortunately, we can't always cure the issues, but we certainly can optimize your function and quality of life. So we'll start with kind of the basics. So everybody listening, and I understand we have a lot of patients, and I'm guessing patients' family members and loved ones. We have a lot of clinicians out there. Well, everybody in this audience, even the 24-year-old marathon runner out there, comes to the table with a bunch of medical and degenerative changes. That back issue that you had a while ago, the neck pain, the shoulder issues. Some of you might have diabetes or be overweight. Whatever it is, you're going to come to the table with that. And then when you get head and neck cancer, really any cancer, the treatments are going to be usually multimodal. So we may operate, we may give you chemotherapy, which often has a number of complications associated with the chemotherapy. And then we're going to give you radiation, which in head and neck cancer is really kind of the primary cause of the issues that we see. Nowadays, it's not just chemotherapy, but there's also a lot of immunotherapies, targeted therapies, hormonal therapies, what is better referred to as systemic therapy as opposed to chemotherapy. If we had more time, I'd be delighted to go down the rabbit hole of telling you what the differences are. But suffice it to say that some of these new systemic therapies are unbelievably efficacious in controlling cancers like melanoma that we really didn't have good treatments for. So in head and neck cancer, right, usually you're going to have a primary tumor. It can be at the base of the tongue or in the tonsils. Often the lymph nodes in the neck are going to be involved, which you can see here, this large tumor. And you may, even if you're not a doctor, right, or a clinician, you probably understand there's a lot of important stuff in the neck. It's small in most of us, and there is a lot of stuff packed in there that is absolutely critical. So when we're taking out that tumor, we can damage those things. The systemic therapy can make it worse, but particularly the radiation therapy is the primary cause of issues. Again, I'm going to go into that. So we'll often do a neck dissection in head and neck cancer, and this is the source of some confusion. Everybody out there is going to say, if you had a neck dissection, it was radical, right? Which is not really technically true because it has a very specific medical term. So a radical neck dissection means you take the lymph nodes in all of these areas. So level 1, level 2 at the top of this muscle called the sternocleidomastoid, 3 in the middle, 4 at the bottom. 5 is what we call the posterior triangle. A lot of important stuff in the posterior triangle. And 6 is sort of the anterior neck down here. So in a radical neck dissection, we would take all of those lymph nodes, but we would also take some very important structures like the sternocleidomastoid muscle, the spinal accessory nerve, which is critical for shoulder function. Oh yeah, the internal jugular vein. Apparently you can live without one, but you really don't want to have to. More commonly nowadays, we'll do a modified version called a modified radical neck dissection, where we'll take all those lymph nodes, but we'll spare one or more of those other structures. And when we can, you may have had a selective neck dissection where we just take like level 1, 2, and 3. We don't take the big structures, although they absolutely can be damaged during the course of the treatment. And then the radiation. So radiation I liken to the gift that keeps on giving. Even though the radiation is out of your body, that radiation causes these permanent damages to the tissues that were in the field that can continue to progress for the rest of your life. We used to say, oh, it can progress for 20 years. Well, now we know people live a lot longer than that because we've gotten so much better at cancer. So I have survivors with severe radiation late effects 50 plus years out surviving their initial treatment. So what is radiation? Well, you're using it right now. You're watching me thanks to radiation coming off the computer screen that you're watching me on. I am lit in radiation. This is a light energy. It's not particularly high power. It doesn't do any significant damage to us. But when you get to really high-powered radiation, enough that can ionize the tissues, that then is what kills the cancers. And it kills the cancer cells preferentially over normal cells because of an issue with the cancer cells is that they're rapidly dividing, and that makes them very vulnerable to both neurotoxic or cytotoxic chemotherapy and radiation. Nowadays, there's a couple of ways, a couple of sort of forms of radiation we give. One is photons, again, bathed in photons right now. The other one is protons, which are actually little particles, which are very different. And they have different ways of affecting the tissue. So some of you out there may have received proton radiation, which is a newer, very expensive therapy. Photons, the old school way, which we still do, doesn't mean it's any less effective, I liken to a bullet. When you generate it in the linear accelerator, it has a certain amount of energy, like a bullet, being fired from a gun has its peak power and velocity right when it leaves the muscle after all the powder is expanded behind it. As soon as it hits the air or hits a target, hits a wall, something like that, it loses its power until at some point it stops. Just like light, or if I was shining a light through a paper, the thicker the paper gets, the less light can penetrate it. So that, as you can see on this peak here, hits its highest level, right, and then tapers off. And that has some implications I'm going to talk about. The protons are more like a torpedo. They're going to leave a mark if they hit you. They have a certain amount of energy, but they are calibrated that when they're all spinning, gets to a certain level. It explosively releases that. The beauty of that is you can get it deeper into the body before it explosively releases that energy, as opposed to photons that have to come in and their highest sort of energy is when they come through the skin. Why is that important? Well, we have to modulate the radiation. So the radiation you would get for head and neck cancer is what's called intensity modulated radiation. So this is a picture of leaf columnators that can change their shape and flow in and out of the screen that both shape it and attenuate how much radiation is getting through. So by using this intensity modulated radiation, we can sculpt it and we move it in circles around. We can sculpt that beam to miss important structure. So for instance, this is a head and neck cancer, what's called isodose curve. And red is where you get the max dose of radiation, whatever that happens to be. Let's say it's 5,000 gray or 54 centigrade. And the spinal cord here, we don't want to mess with the spinal cord too much, gets a lower dose. Still gets some, it gets a lower dose. And literally you got cold shoulders out here, right? Because the nature of the way we're giving the radiation, they don't get in the field very much. So what's important about this? Well, there's still, even though we may have done a neck dissection in this patient, looks like that little dissection over here on this side, there's a lot of important stuff in this high dose field. And if you know any, anatomy, the nerves coming out of the spine are here, the plexus, which is an interconnection of nerves, is here, muscles are in here, your carotid arteries are in here, your vertebral arteries in here. We're going to talk about swallowing issues. A lot of the stuff that helps you swallow is in here. The lymphatics that drain the fluid out of your head are in here. So all of those structures can take a hit. And as I said, it's the gift that keeps on giving. So they can take this progressively worse hit over time. So these are penguins in Macquarie Island down near the Arctic. And again, this is the closest to crowding to allow me to talk about radiation fibrosis syndrome. So what happens in radiation fibrosis syndrome is those tissues are damaged by the radiation, and what is a normal protein called fibrin starts getting deposited in the tissues abnormally and not cleared properly. So that's the fibrosis, right? Is this sort of stacking up like penguins on a beach, right? Of this fibrin, so that this poor elephant seal is going to have a little bit of trouble getting out of here. Although he's big enough, I'm pretty sure he could make his exit if he wanted. But that's the fibrotic part. Radiation fibrosis syndrome then are all the bad things that happen to you as a result of this fibrosis, this hardening of the tissues. And a lot of you may feel that in your neck, right, in other parts of your body that may have been radiated. A lot of things determine if you're going to get fibrosis. So one of them is the total dose. So in head and neck, we use a lot of radiation. So regardless of if it's protons or photons, the dose could be like 70 gray, which is a significant amount. And we give that usually in like 35 treatments, right? And everybody wants to say, oh, I had 35 treatments of radiation. What's really important is the total dose, or if we know 35, that the size of each dose so we can calculate up the total. The higher that total dose, as you would imagine, the more tissue damage. Other treatments you had, if you had a neck dissection, right, you've already got surgically damaged tissue that's now being radiated, and that can become an issue. The type of tissue I'll show you in another slide. Certain tissues are more resistant. Other tissues like lung are very sensitive. Time, again, the gift that keeps on giving. So the further you're out from radiation, the more likely you are to have issues. And then what I call protoplasm. Protoplasm is like just you, right? Are you somebody who heals well from these things? Some patients, for reasons we don't understand, get bad fibrosis early at low doses, right? You have diabetes or a lot of other neuromuscular, musculoskeletal issues that make the signs and symptoms you get more profound, more significant than another patient. So this is just looking at the dose. So lung, like I said, this is total dose, right? So head and neck cancer, you get 70 gray to the primary tumor. The neck may get 50 or 54 gray. And this is the total dose to cause complications at 5 years. What's the problem with that? I'm guessing some of you on the phone or on this call are further than 5 years out, right? So my kind of thing is if you go long enough after the radiation, you're going to have issues. It's really just a matter of time. So again, lungs very sensitive, but nerves are more resistant. But again, when you're up to 70 gray, people start getting issues. And most of the head and neck cancer patients I see have clear neurologic issues. They may not be really messing up their function and quality of life, but they have clear issues as a result of the radiation. All right, so the great Yogi Berra, it's tough to make predictions, especially about the future, but why don't we try? So in head and neck cancer, the complications are pretty common, right? I mean, we know, and we can template that there's a handful of things that we really need to take a look at and assess for. These are the things that you are likely to have. And when patients come to me, they'll usually come to me with neck pain or shoulder pain, or I'm having trouble swallowing. And invariable, I will find multiple other issues that they didn't really know about or didn't rise high in their level of concern that I'm worried about, because I want to make sure they're as optimally treated as possible. If you're having trouble swallowing and it's just a little inconvenience, like, oh, I have to drink more water with my food, well, I want to send you to one of our fantastic speech language pathologists to assess you and make sure that we're doing everything possible to delay your swallowing problems into the future. So everybody comes, as I said, with all their other medical issues, regardless of who you are. You've had some sort of medical issue. Nobody gets to be old enough to watch this call without having something, right? Then you go to surgery often. Sometimes the roles reverse. That's going to cause damage of the nerves, like I showed you from the neck dissection, or trouble opening your mouth, or trouble swallowing, or swelling in and of itself, right? Then often we get combined chemoradiation in head and neck cancer, and that's again going to potentially cause neuropathy, or trouble walking, or trouble buttoning, fatigue, chemobrain, cognitive impairment. It may worsen the lymphedema. Then often you get to ring the bell. Great, I'm done with my head and neck cancer treatment. You start feeling better, right? So the red on my little line here starts going back to yellow and to green, indicating that, oh, you're doing better. But then sometime in the future, that might be 3 months, it might be 6 months, it might be 6 years, it might be 26 years later, you start developing issues. And very often the doctor has no idea. Oh, it couldn't possibly be a radiation. That was way too long ago. I hear that all the time. But again, the gift that keeps on giving. You start getting these issues, and then it's up to us to try to identify, evaluate, and treat those to the highest possible level, including damage to the spinal cord, because again, it's in the and the nerve roots coming out of it. The plexus I showed you was in the field. The nerves are in the field. We get a number of what we call cranial neuropathies, and then the muscles are in the field. People have trouble lifting their head up. You can get necrosis of the jaw, and again, things like depression, anxiety, lymphedema, swallowing issues. All of those get worse as a result of the radiation. So just talking about a few of them. Trismus, very common. This is inability to open the mouth. If you guys are out there, you want to tell normal, and I have a shockingly small mouth for being such a big guy, you should be able to get 3 fingers in your mouth is what we consider sort of normal as a screening. Or we use a special tool to look at 35 millimeters. So some people might be 60 millimeters coming in. There's some people who can really open their mouth. There might be people like me who are probably 25 millimeters at normal. But here's somebody trying to fully open their mouth. And as you can imagine, this is the problem because you can't get in there to brush his teeth. We can't get in there to look for cancer. You get bad breath, right? If you have a cavity, we can't fill it. If you need a root canal, impossible to do. So it's a big issue having trismus, but there's ways to try to, treat it. We can't cure everybody, but certainly can help. Cervical dystonia, meaning neck spasms. That fibrosis often is set with the muscles being really sore and painful, kind of pulling you to the side like this gentleman. Extremely common in head and neck cancer. And again, this is something our therapists are really just unbelievably good at treating. But oftentimes, I'll also do Botox injections. So all the ladies looking lovely because the Botox, what it does is it poisons where the nerve, in some men, talks to the muscle. So it forces that spasming muscle to relax. And if you're getting it cosmetically, that relaxes the wrinkles. It wears off as your nerves start branching around. And so it wears off in a few weeks to a few months. But in patients with head and neck cancer where those muscles are really painful and spasmy, I often will start with therapy, but sometimes actually everybody gets therapy. I'll go and I'll put a little Botox in the muscle, in the sternocleidomastoid and what's called the scalenes just behind. And that can really help patients, particularly with the pain, and that will allow our therapists to be more effective when they treat these patients. Dropped head syndrome. Of course, I'm going to show you the worst of the worst, right? So here's a lady with profound drop head syndrome. And worse, because of the dystonia and the fibrosis, she's stuck down here. She really cannot lift her head up, except more than a little bit. It doesn't start like this. It usually starts with they're leaning back like this all the time when they're talking to you, or they come in and they're talking to me like the thinker, right? Or they just describe that their pain in the back of the neck gets worse later in the day. And often because everything's pulling you forward and you get into this sort of C shape, having our therapists do a lot of manual techniques, myofascial relief, deep breathing, and a lot of other things to open you up, get you back in your upright and locked position, that can work wonders for improving. And I'll use collars sometimes and other things, and I may have to get pain meds. After might keep occasionally. I can't let the therapist have all the fun, although they're really critical to this. But we usually can help people with dropped head syndrome be as functional as possible. We can't always cure it, but we certainly can optimize it. Shoulder dysfunction. Again, because of the neck dissection affecting the spinal accessory nerve, which is one of the big, works that big muscle up here. You can see how small it is in this guy on the right. And other nerve, that shoulder is winged. So this guy's big complaint when he first came was he couldn't put anything in the overhead on an airplane, right? He had to ask for help because that shoulder just was so unstable. Again, we can't cure this, but we certainly can optimize it and make a patient like this more functional. And this guy has pretty profound damage. You can see the radiation tattoos here, but it's the nerve roots, the plexus in here, the peripheral nerves, and then the muscle themselves in the field over here on his right side are all damaged by the radiation. That's all he had. He had 5-FU chemotherapy, but that wouldn't have done this. This was all just a radiation-late effect. And then lymphedema. Again, this is almost effectively 100% of head and neck cancer patients with locally advanced disease will have lymphedema. That's abnormal swelling characterized by a lot of protein in there. That protein sets up like concrete, right? It's also fibrotic. It's also inflammatory. So I like to be as aggressive as possible about getting the fluid moving using our lymphedema therapist or certain types of pumps to try to get that fluid going. And I think that helps with their ability to swallow long-term and a variety of other issues. And just because your face doesn't look big and puffy doesn't mean you have it. If we image people, the structures internally are all a little bit thick. And if we can get them normalized as much as possible, that often helps in and of itself with some of the issues the patients have. But again, Those of you out there thinking, oh boy, I got to go see a doctor about this, happy to see you. But the truth is, you come from me, you stay for the therapy. Far and away, the most important part of your long-term management is going to be what our therapists have you doing to try to help improve and maintain your function and quality of life. And my job is to make their job as easy as possible in support of that. All right. So now I'm going to turn it over to one of my great colleagues, Jen Hrdina, who has taken care of more head and neck cancer patients than I can recall. And literally, they come to me from all over the world, but they stay because of Jen's magic hand. So enjoy listening to her talk.
Thank you. So as Dr. Stubblefield said, my name is Jen Hrdina. I've been an occupational therapist for 15 years. The entirety of my career, I've been here at Kessler. I am a certified lymphedema therapist, and I am a Revital cancer therapist. So what is occupational therapy? Occupational therapy is defined by the American Occupational Therapy Association as a means of therapeutic use of everyday life occupations with persons, groups, or populations. So what does that mean? Occupations are everything that we do throughout our day: dressing, bathing, gardening, yard work, bird watching, and photography. In a traditional outpatient setting, occupational therapists work to address physical needs for our patients so that they can increase their independence with their activities of daily living. How can occupational therapy help with recovery? There are many different ways that occupational therapy can help someone who has a history of head and neck cancer and fibrosis. And I'm going to go through each of the ways that we can help address these different deficits that someone might have. So what is lymphedema? As Dr. Stubblefield mentioned before, lymphedema is a chronic progressive condition that causes swelling in a body part. It occurs because of a protein-rich fluid that is accumulating in the tissue. Lymphedema can occur due to the result of cancer treatments, including surgery and/or radiation. Radiation can affect the lymph nodes and the lymphatic structures. There are 4 components to effective lymphedema therapy, also known as complete decongestive therapy. The first is exercise. It's important to use an individual's muscles similar to pumps to help remove the excess fluid from the region. The second important component is skincare. Moisturizing regularly prevents any dry or damaged skin, and it reduces the risk of infection. It's also important to take care of any cuts or nicks on an individual's face, especially after shaving. We want to make sure that we're addressing bug bites immediately. All of this helps reduce the risk of infection. The third component to effective lymphedema treatment is manual therapy or manual lymphatic drainage. Manual lymphatic drainage physically pushes the excess fluid into a different part of the body that can effectively drain and get rid of the fluid. So an individual who has head and neck cancer, we would typically push the fluid towards the arms, towards the armpits in order to get rid of that fluid. The last component is compression. In order to maintain the progress that we have with the manual lymphatic drainage, we want to make sure that we're using compressive garments. Someone should reach out to their physician or a lymphedema therapist if they notice heaviness, swelling, tingling, or even a change in how someone's clothes fit, tight neck collars, or difficulty tying a tie that you were once able to do. Also, if someone has difficulty swallowing or difficulty speaking due to swelling, that's when you're reaching out to your physician or your lymphedema therapist for evaluation and treatment. OTs can also assist in increasing someone's range of motion, decreasing pain or discomfort by performing manual therapy. Manual therapy may be needed because of tight muscles due to postural changes or non-use of certain muscles, or because of fibrotic changes occurring due to the radiation and the prolonged lymphatic changes. There are different types of manual therapy that can be performed. The most recognizable is soft tissue mobilization. OTs can also perform myofascial therapy, which is a very gentle stretch of structures and tissues, which affects how the muscles move. OTs utilize different tools such as cupping or the lymphedema, which vertically pulls the impacted structures up to allow a more effective lymphatic flow and more effective movement to occur. OTs will address someone's range of motion. Deficits can occur in the arms or the shoulder blades, as Dr. Stubblefield did show. We would prescribe different exercises. OTs can also address the range of motion and the strength of an individual's neck. Typically, this is addressed in physical therapy, though. Often, an individual's strength is affected as well, whether it be because of medication side effects or surgical side effects. OTs will work to assess an individual's grip strength for increased independence, opening jars, opening bottles. We can also prescribe or recommend different adaptive tools for home. If an individual may have some peripheral neuropathy because of medications, that can lead to decreased dexterity or coordination, OTs will work to prescribe prescribe exercises to increase the person's ability to manipulate objects in their hands. A big area that we work to address is posture as well, to ensure a person is not only sitting and standing straight, but to ensure that their chest is open for effective breathing and increasing the individual's endurance. In order to effectively address postures, OTs will prescribe exercises to increase the strength of the neck, abdominal core, and scapular muscles. OTs can also perform taping, whether kinesio tape, which is similar to what athletes wear to assist in eliciting muscle activation or inhibiting overactive muscles that are impacting a person's posture. Another type of taping that we can perform is McConnell taping. If a muscle group is weak, McConnell taping can help sustain a prolonged position in order to assist someone in their breathing or in their posture. Lastly, and most importantly, OT is there to ensure a patient has increased satisfaction with performing their daily activities safely throughout the day. OTs will discuss everything from toileting to bathing, how an individual is doing with their personal hygiene, and we look to teach remediation or compensation, also ordering adaptive equipment, trialing that adaptive equipment in order to ensure that the person is independent and functioning safely throughout their everyday activities. Brittany is now going to discuss speech therapy and how it can impact an individual's recovery.
Thanks, Jen. Hi, everyone. My name is Brittany Boynton, and I'm a speech language pathologist and Revital Cancer Rehab specialist here at Kessler. I'm going to talk to you a little bit about my role in the head and neck cancer rehab process. So one of my primary roles as an SLP is to assess swallowing function at different stages of treatment. This may include clinical swallow evaluations or instrumental swallow assessments, such as a modified barium swallow study or a FEES, which is an endoscopic swallow evaluation. We're also going to provide a variety of speech and swallowing therapies depending on what deficits we're seeing. Sometimes we'll use manual techniques such as myofascial release to treat the radiation fibrosis. And of course, we're going to provide you with a lot of education about how to manage the range of symptoms that may come up after treatment. No, you're good. Next slide, sorry. So many patients who have undergone head and neck cancer treatments present with dysphagia, which is a general term for a swallowing impairment. This may be caused by damaged structures because of the radiation fibrosis, resulting in weakness and reduced range of motion. These structures may be damaged from the radiation treatments or the surgeries. Some symptoms associated with dysphagia could include aspiration, which is when food or liquid enters the airway or the lungs, poor swallowing efficiency or bolus clearance, dry mouth, which we'll get into a little bit more in just a minute, pain during chewing or swallowing, and then malnutrition or dehydration may result from some of these issues if not managed properly. So how do we manage these swallowing changes? The swallow is broken down into a couple phases. So if there are impairments in the oral phase of the swallow, such as difficulty chewing or manipulating foods or liquids, we can work on oral motor exercises to strengthen the lips, the tongue, and the cheeks. We may also recommend modification of textures to make foods more manageable. If there are deficits in the pharyngeal phase of the swallow, such as poor airway protection or difficulty clearing the food or liquid, we can do swallowing exercises, which target the specific muscles involved in these functions. And again, we can modify food and liquid consistencies. And we can also recommend a variety of strategies or maneuvers to compensate for some of the deficits that we see. So how can patients with dysphagia optimize their function? It's important that you follow up with your SLP regularly, get a yearly swallow test to monitor changes, because if we stay on top of it, we can address these issues as they come up. Do your home exercises regularly, comply with the recommended diet consistency and use of trained strategies, use good oral hygiene to prevent infection, use your safe swallowing strategies and precautions to reduce aspiration risk. We want to monitor for the signs and symptoms of aspiration, such as coughing, throat clearing, temperature spikes, and just make sure that you're reporting those to your SLP or your physician. Okay, so dry mouth is one of the most common symptoms that I see with my patients who have had radiation. It's caused by damage to the salivary glands if they're included in the radiation field, which often they are. Dry mouth can cause difficulty with eating dry or hard foods. Mastication and manipulation of food might be uncomfortable. It can also impact taste changes, difficulty with speech, and also creates an increased risk of infection and dental compromise. So there are some preventative measures listed here to prevent dry mouth from happening. Oftentimes these techniques are not appropriate, so we do have a variety of ways to manage dry mouth if it does happen. So stringent oral hygiene is really important to reduce the risk of infection. That might include the use of fluoride agents and antimicrobials. In addition, patients may require the use of saliva substitutes, and there's a huge variety of agents to stimulate saliva production as well. So how can patients with dry mouth optimize function? Find out if you're a candidate for preventative techniques if you haven't already undergone treatment. Work closely with an SLP and a dental oncologist specifically. Use trial and error. There's a lot of different dry mouth products out there, and I've found that each patient has their preference and just what works best for them. You want to make sure to keep water and any saliva substitutes or stimulants handy at all times. Practice good oral hygiene and modify textures as needed. All right, so I'm going to very quickly touch on some speech and voice impairments we might see as a result of head and neck cancer treatments. So dysarthria is a general term used to describe speech disorders caused by muscle weakness. We may see poor movement in the tongue, lips, or jaw due to radiation, surgery, what have you. And this can result in poor articulation, changes in speech rate, and changes in nasality. Dysphonia is a general term used to describe voice disorders caused by vocal cord dysfunction. And that can have a variety of underlying causes, but it can present as changes in vocal quality like hoarseness, difficulty controlling pitch or volume. All right, so some very general ways to manage these impairments and optimize function may include oral motor exercises, compensatory strategy training, such as over-articulation, voice exercises, respiratory exercises to improve breath support, and education that we might provide on vocal hygiene. In more severe cases, with augmentative and alternative communication devices may be introduced, which is what your speech therapist will help you find the appropriate one. And this is all just kind of what I just went over, actually. So I'm going to kick it back to Dr. Stubblefield to wrap up here, and then we can get into some questions and discussion.
Well, that was fun. So thank you, both Jen and Brittany. Fantastic. So again, we're looking forward to answering questions, and I think we did a pretty good job of getting through this. So, you know, big point take home for you guys is remember radiation in particular is the gift that keeps on giving. So very often, if you're developing issues 20 years later and somebody's telling you they couldn't possibly be radiation related, you might want to consider otherwise. You want to stay in front of issues. I think we don't have great data, but we believe that if we try to give you exercises and strategies to prevent some of these complications, we will delay them. We can't always prevent them, but we believe that. Radiation can contribute to other issues in unexpected ways, right? So if you have radiation and diabetes, you can get signs and symptoms that are very atypical. A team is critical, right? So again, it's a joke. You come for me, you stay for them. But the truth is we are much better as a group. And the physician, the physical therapist, the occupational therapist, speech language pathologists all have different skill sets. And head and neck cancer patients coming to me will often go to all of them. So I'll send you to a physical therapist working on the myofascial techniques, getting your shoulder back, getting your neck back, working on range of motion, that sort of thing. Occupational therapy, they'll go to Jen to do just the lymphedema because that's an involved thing. And then, of course, they would go to Brittany to work on their swallowing issues. And patients may have to go back repeatedly, meaning we'll get you through that initial course, and then periodically we're sending you in for tune-ups on things, and I'm kind of the quarterback following and trying to time when it's best to do it. It's not about draining your insurance, it's about providing you the tools you need to live as well as humanly possible. And again, in head and neck cancer patients, you're among the most complicated group of cancer survivors we have. So again, nobody's going to cure you. Anybody telling you they're going to cure you is probably not speaking true. Our job is to help you live your best life. And that's what we're all trained to do. That's what our passion is. And that's what we want to do to help you. So that's my contact information for anybody who wants into the Kessler system. We also have Vital Cancer Rehabilitation. This is the largest cancer program probably in the world. I think it's safe for me to say about 1,000 therapists operating really all over the country in 20 some odd states and growing. So our goal is to bring comprehensive cancer rehab everywhere. We understand that, you know, we're sometimes very hard to find. And thank you all again, Shelley, you and your team for letting us say our piece. Oh, you're on mute. Told you the biggest mistake.
Dang it.
Jen, Brittany, get off mute quick.
Yeah. Thank you all very much. It was a really informative presentation. Dr. Stubblefield, you always explain things, all these complex medical concepts very clearly. So I really appreciate it. I just want to start with a question of, so say you're a cancer survivor, you have some challenges as a result of your treatment, whether it be head and neck or otherwise, like how do you start? Because I know we've talked to you before about our, you know, knowing that you all have so much to offer people, but cancer survivors don't always know about it or find out about it or get referred to rehabilitation. So if you know you're facing some of these challenges and you think you need help, like where do you start? How do you how does someone who doesn't live near you and can't come to Kessler, how do they get started?
So a quote sticks with me. The secret to getting anywhere is to getting started. And whoever asked that question has already got it started, right? You're already here. You're already on the call. You're already tied to the NCCS, which is an amazing organization. So you're already there. What you know from this is now you got to advocate for yourself. You know that there are physicians out there. There's not a lot of cancer rehab physicians. So finding one may be helpful, but educating a physiatrist or a neurologist, an orthopedist, or your internist on the fact that you need things is helpful. And then finding therapists who may not be anywhere near as experienced or trained as Brittany and Jen here, but may have the core elements, particularly if you find somebody who's interested in finding out information, right, who can, you know, hopefully grow with you in the treatment of some of these things. Brittany, Jen, do you guys have comments on that? It comes up all the time. We get patients from all over the country, and then we have to send them back to be treated locally.
Yeah.
I think you touched on it before, Dr. Stubblefield, making sure that when you are seeking out therapy, it's a comprehensive team. It's not just a physical therapist. It's not just an occupational therapist or a speech therapist. We're lucky enough to work in a facility that we have all disciplines together, but making sure that you are going somewhere that you can be seen by different specialists is definitely key.
I think it is also important that that you make sure that whatever therapist you're going to work with does have a background in cancer rehab, because a lot of what we do in speech pathology with swallowing in particular, we approach it very differently in the cancer rehab population than we do in some other populations like stroke and traumatic brain injury. So it is important that you find therapists and specialists in cancer rehab.
Dr. Stubblefield, do you do telehealth visits, and could you put together a plan for somebody to then go to someone in their community to get support?
Yeah, that's a great question. The answer is yes, I do, but sadly only for New York and New Jersey now, because they changed the rules on us, which was a big problem because I had patients in Alaska and California, and now they have to come in person. And our therapists really picked up the ball and ran with it during the pandemic and became really good, particularly on the speech language side, because that is very conducive to virtual visits. So the answer is yes. What I'd recommend for people who are really wanting is come be assessed by us. We'll do like a rehab vacation, for lack of a better term. I'm always looking for a better term. So patients will routinely reach out to, you know, usually me, and then we'll schedule them to see me. I'll go ahead and put in orders for PTOT, SLP without having seen them. I'll see them on a Monday. They'll work with our therapist 5 days a week for a couple of weeks. And at a minimum, we get a good sense of them so that we can help guide them at home. I know it's resource intensive, right? Flying out and staying with us and everything that's involved. Our goal is, again, to try to equip you with the tools. Some patients will stay longer. But yes, I'm happy to do telehealth visits, but again, unfortunately limited. I'll put in a plug, talk to your congressman, talk to your senator, because I think it's a big problem.
Yeah, there were a lot of flexibilities around telehealth during the pandemic, but they ended. And so including that telehealth across state lines, which is a challenge. What about insurance coverage? Does insurance cover long-term rehabilitation therapy, all of the different elements of it for cancer patients?
We are function-based in terms of the billing. I'm not billing you as a cancer survivor. I'm billing you for cervicalgia, neck pain, or dropped head syndrome, or Brittany's billing for dysphagia, or Jen's billing a lymphedema code, right? So the codes are based on your impairments, not the fact that you have cancer. So if they would cover you for injuring your knee, you know, playing squash, they would cover you for seeing us.
And how big of a barrier is it for people that is insurance coverage? I mean, you know, are most plans pretty good at covering some level of physical therapy or rehabilitation, or are there limits and it's not enough for what somebody with a serious impairment might need?
Jen?
We try to figure it out with our patients. So every insurance, we have to justify the means for skilled intervention and medical necessity. There always has to be justification in reimbursement, but we figure it out with individuals. If someone has unlimited visits based on medical necessity, we can definitely keep them on program for a little bit longer period of time. If someone's insurance visit limitations are 15 for the year and we're in February, we are going to figure it out with them. We're going to do a full assessment. We're going to issue them exercises. And throughout the year, we're going to check in with that individual so that we're continuously updating their program, continuously addressing their needs, so that we we figure into the insurance limitations and we work with them and around them to ensure that our patients are getting the best treatment possible.
Thank you. So what should head and neck cancer survivors most want their primary care providers to know when caring for them?
The issues are related to radiation, right? You know, it's funny because I did a thing for cancer, like for the American Cancer Society, a big multi-author sort of position thing that was meant for primary care. And I think this thing ended up being 50 or 70 pages long, which means there's almost impossible that there's any significant number of primary care providers in the world that have had a chance to thoroughly digest that. So you guys, as the ones suffering, right? Or I know there's a lot of other clinicians recognizing that their shoulder problems, their neck problems, their swallowing, their swelling, and other things you may not have recognized could potentially be a component. That's the important thing, is a recognition. And then what we just told you, what Jen and Brittany so beautifully and eloquently said is, you may need multiple clinicians to optimize you, right? So don't be pigeonholed as, oh, I'm sending you to physical therapy, that should be adequate. No, that's adequate for a couple of things. You need somebody who knows lymphedema, you need somebody who knows speech and swallowing as well. Jen, Brittany, thoughts?
You nailed it.
Okay, good. Glad to be of service.
Okay, so as you mentioned, we have both survivors and healthcare providers on the webinar, and this question is from healthcare providers saying, how can I advocate for my patients with head and neck cancers?
For me, it's the same answer, right? Recognition. I'm just, it's epidemic that I get patients coming in saying, nobody told me this could happen. And then when I tell them, they tell me it's not from the cancer treatment. And then when I tell them it is from the cancer treatment, they say, well, I have no idea how to treat it. So the fact that you're all here means you are part of our team now. Thank you. We welcome you. And when in doubt, refer them out. We are very happy. I'm happy to get on the phone with any of you, of the providers, to kind of explain it and to talk about your patient. Again, we're in this because we're passionate about it, right? We want to make sure that we raise the bar across the country for people understanding these issues.
And I think you can advocate for them just by providing a little bit of education and then making the proper referrals. And just explaining that all of us should be involved in their care, like Dr. Stubblefield said.
Great. Thank you. Can you talk about the level of additional radiation involved in swallow tests?
So it's so minimal. It's like, when we do a video swallow study, in terms of radiation exposure, the actual radiation exposure typically in terms of time is only a couple minutes. So the doctor doing the study is turning the radiation on and off. It's not a continuous dose of radiation, and usually we track it during every study. It's usually under a milligray. So it's nothing. It's nothing
Right.
to be a concern about.
Yeah, remember 70 gray for a milligray, so 1,000th of a 70th, right?
Yeah.
Whatever that is. The 1/70,000th, am I doing my math right? And part of the reason for that is a photographer, and thanks for the shout out, Jen, on the bird watching and the photography as occupation.
I put that in there for you.
I saw that, I was smiling, I almost came on the screen like this. But, you know, the sensors have gotten so good, which is what allows us. Like in the olden days, you were exposing film, which was crummy for gathering light. Nowadays, you've got this super high sensitivity sensors that just, it's microscopic radiation and a non-issue. You get more flying in a plane.
Yeah. And don't let it deter you. The test is extremely valuable. So do not let it deter you from getting these tests done.
So does your program have a psycho-oncology component as well to help people deal with the psychological effects of these challenges?
Sadly, no. That's like, yeah, it's like one of our weak spots. That and nutritionists, like on staff, are two of our big issues. We don't have them for a variety of reasons. What we do have that, you know, it's a bad answer to a good question, is our SLPs and our OTs are all trained in cognitive rehabilitation. I know it's not the same thing, but it does help with some of the issues a lot of the patients are having, but we're not actually doing sort of the psycho-oncology component. Although most patients do feel better if we're helping them with their functional issues.
Yeah.
What about if you have a surplus of saliva that interferes with eating, speaking, swallowing, how do you deal with that?
So it depends on the underlying reason for the increased saliva production. Sometimes it's actually an increase in mucus, or it's an increase in saliva that's actually not really serving the same purpose that your normal saliva would. So a lot of my patients complain of these like frothy secretions, and they don't actually have the enzymes that good saliva has in it to break down food and liquid. So it just depends on, is it truly saliva? Is it mucus? Is it a combination? And what's the underlying cause? Is it because the patient is having difficulty swallowing and therefore they're not managing their saliva very well? So it really, the answer would vary just based on the underlying cause. It may be indicative of a swallowing issue.
Right. And I have a number of these patients. I actually Botox the parotid gland and the submental gland, so which can be useful to dry up the secretions if they're truly saliva.
There was another question of like, when is the Botox indicated?
Anytime you're having neck spasm, a lot of patients are like multiple spasms a day. They can't turn their head. It sends them off. Some of those all Botox up front, like it's kind of like, yeah, let's just Botox. If you know how to do it, it's easy. I have a pretty much zero complication rate. It's not even that uncomfortable. I kind of joke, it only hurts them slightly more than it hurts me to bend over and do it. And, you know, it literally takes seconds. It took me longer to explain it now than it does to actually do the procedure once it's mixed up. And then you'll know, you know, some patients need higher doses than others. The real trick there is finding a physician who knows how to do it. But when you're starting to get that cramping neck pain, it's a chip shot to do these muscles for somebody who knows how to do it.
Now, if someone has radioactive iodine treatment for thyroid cancer, does it cause the same kind of fibrosis that radiation would?
Yes and no. So for typical thyroid cancer, it's a very high dose locally, but usually doesn't cause issues. Like, I don't know that I recall, maybe Jen or Brittany have. If it's metastatic disease, that's a different story. So I've seen patients who have like metastatic disease to the spine who got radioactive iodine for it and actually got spinal cord injury from the high dose of radiation. But that's a very rare thing. For the typical radioactive iodine dose, it's not, because it's very little tissue that's actually getting it, so the concentrating effect is very small unless there's a big mass.
Okay, does fibrosis cause symptoms such as sore throat and blood pressure instability? And if so, can this be addressed?
That's a good question. Brittany, you want to do the sore throat and I'll do the blood pressure?
Sore throat, I really haven't had many complaints of the radiation fibrosis causing a sore throat. Perhaps just I'm more so soreness in the area, but not as much internal. I haven't had many complaints about that.
Yeah. So again, I've seen it more commonly be in the setting of somebody have thrush or another infection, or somebody with like an ulcer or fistula that's not healing from the radiation, which we see occasionally. So it's not a typical thing. Now, the blood pressure instability, that's interesting because there's something called baroreflex failure. So your carotid arteries bifurcate, meaning they split in your neck to go into different parts of your head. And sitting right there, because it's very important to have blood flow to your brain. Some people would argue I do not have adequate blood flow to my brain. So your body really tries to preserve that blood flow no matter what. And that's what those carotid baroreceptors do. They're like a thermostat. So what happens when your thermostat starts malfunctioning in your house? Your heat shoots up and your heat shoots down. So in this case, your blood pressure, I've had patients will shoot up to 220 and they'll get headaches and be symptomatic, and it'll crash to 70 or 60 and they'll be passing out. Or their heart rate's always running 120 and it'll go up to 160, or they'll have an arrhythmia and then it'll drop to like 30 or 40 and they're getting dizzy. So that's called baroreflex failure. It's supposedly rare. Like the biggest series ever, I haven't looked in a while, like 25 patients of Mass General. We probably have 100 in our practice that have it right now. It's actually a known entity for all of our therapists. So that it's hard to treat. Vanderbilt is probably the best autonomic lab in the country. I've got a couple of local people I refer to who are good, but not really doing research in it. we'll try to close the floor. Like we try to make sure you're not passing out. And unfortunately, we have to tolerate you being high clonidine, which is a medicine that can help blunt those, is sometimes used in patients. Long question. Like I said, after my teeth around here. So thanks for asking that.
Are these issues unique to head and neck cancers or just more common in head and neck cancer survivors?
Great question.
Obviously, you all work with people with all different kinds of cancers, not just head and neck cancers. So,
Jen, Brittany, you guys want to take a stab? I feel like I do all the talking these days.
Lymphedema, stiffness, loss of motion, neuropathy. We do see that with individuals who have other different types of cancers. The difficulty swallowing is definitely more associated with the head and neck cancers, and the difficulty speaking as well. But we do see other individuals who have different types of cancers with other complications because of treatment, because of just the course of their cancer.
I really only do head and neck cancer because speech pathology kind of operates from here up.
Oh, you also do Hodgkin lymphoma.
Well, yes, that's true. That's true.
Right. So, yeah.
Yes, but I would say a lot of some of the issues, obviously, like the dry mouth xerostomia due to the salivary glands being in the radiation field, are something that's pretty unique to oral and pharyngeal cancers. And again, it's like the #1 complaint that I get.
Exactly. So I think the way I'd answer this is both of them are, of course, absolutely right. Is head and neck's one of the most complicated cancers because it has so many and has some unique features, but the principles that we apply to radiation-late effects and other functional impairments in this group absolutely directly translate to all other groups, right? So Hodgkin lymphoma comes to mind because we get patients who've been radiated years ago who are just really functionally very impaired and have a lot of issues, including dysphagia, dysarthria, lymphedema of the head and neck, and a variety of other issues. And the principles, like once you kind of understand what's getting them there, then our way of trying to optimize it is very much the same, if that makes sense.
great, thank you. So how often should a head and neck cancer survivor get a swallow study?
So at minimum, I would say yearly, even if you're not noticing any swallowing impairments. It's something that can sneak up on people very, very slowly over time. So when I get someone in the door who's just completed their treatments, I make sure to tell them, even if you don't notice any changes, I want you to come back every year at minimum for a swallow study, even if you don't see me. Because if we can stay on top of any of these small changes that happen and get in there with exercise and compensatory strategies, the earlier the better. I have a lot of patients who come to me 10, 15 years post radiation and say, I'm having a little bit of coughing, throat clearing that I'm noticing. Sometimes it takes me a couple swallows to get things down. And then we get in and do the swallowing study, and it's actually much more impaired than it seems to be clinically. So it's very, very important that if you've had radiation to this area at all, get in for your yearly swallow study.
And I'll double down on that. It's rare that I wouldn't say it, but here's the big issue is what Brittany alluded to, is you start aspirating. And when you start aspirating, you start feeling like bad. I'm going to use another word. And when that happens, you lose your energy, you're fatigued, you're getting other things, you're not sure what's going on. And then all the time I'm like, you're aspirating. like it's really not a medical mystery. You don't have to be a rocket science, but I guess it's not common knowledge. So we want to see that coming from a long way away so that we can keep you as good as possible and help you feel better.
Absolutely.
Well, thank you so much. We didn't get to all the questions. I'm sorry. There were a lot of questions, but I just want to end with this one quote because I think it really sums up what we heard. This is from Stephanie Gayhart, who is a nurse and an advocate. And she said, I want to thank you from myself and my fellow young adult tongue cancer survivors. Many of us feel like we're crazy because many people don't understand the long-term effects. And this has been incredibly empowering and validating. So thank you very much for sharing your information, for all you do for your patients, and for being here with us today. We really appreciate it.
Yeah, thanks for inviting us. We're here when you need us again. We're always happy to talk.
Great. And thank you to everyone for joining us today and to the NCCS team for putting this together. And we look forward to seeing you on our next webinar. Have a great day. Happy Valentine's Day.
Happy Valentine's Day, everybody.
Bye. Thank you.